So good morning everyone. Today we are going to discuss about a common topic, that is approach to a child with anemia. This is what we commonly see in our daily OPD practice. So what is the definition of anemia? It is decreased oxygen carrying capacity in the blood, and this is because of the decreased RBC mass or hematocrit, and that decrease is insufficient to meet the body's physiological needs. So technically it is defined as a hemoglobin or a hematocrit which is 2 standard deviation below the mean for that age. So this is the WHO cutoff to define anemia in various age groups. So from this we can see that in 6 to 59 months of age, if there's a hemoglobin of less than 11 gram per deciliter, it is a definition of anemia. And similarly in 5 to 11 years, the cutoff is 11.5 gram per deciliter. And in 12 to 14 years of age, it would be a hemoglobin of less than 12 gram per deciliter. So based on this WHO document, we can see that they have divided the anemia into mild, moderate, severe, and they have written the prevalence of anemia. We can see that around 40% or higher have severe, as per the data they had. 40% or higher had severe anemia, and moderate anemia was seen in around 20 to 40%. Hardly 5% or less than 5% had a hemoglobin which was normal and not in the anemic range. So coming to our Indian statistics, based on the NFHS 4 and 5 data, so the prevalence of anemia in the age group of 6 to 59 months, so we can see that in the NFHS 4 data, it was somewhere around 58.6%, and sadly it has increased to 67% as per the NFHS 5 data, 64 being the urban proportion and the 68 being the rural prevalence. So it has almost increased by around 9 to 10%. So whenever we see a child with anemia, there are few important steps in arriving at a differential diagnosis followed by a diagnosis. So first of all, age at presentation is going to give you an important clue as to what could be the cause for anemia. And then a proper history taking is essential to find out, to arrive at a proper differential and then a final diagnosis. And then the physical examination followed by a complete blood profile with RBC indices and peripheral smear is very important, along with reticulocyte count to delineate what could be the cause for this anemia. And then based on your differentials, you can go ahead with your specific diagnostic test to establish your diagnosis. So as we saw that history is very important, a few pointers that we have to note in history are the age of the child. So if someone is presenting in the neonatal age group, the most common causes would be due to iatrogenic blood loss or isoimmunization. Sometimes we can have hemolytic anemias presenting in this age group, maybe a severe hereditary spherocytosis, etc. can usually present in this age group with anemia. And then the most common hemoglobinopathies, the ones which we see here is beta thalassemia. So if it is a beta thalassemia major, the usual age group is usually they present in infancy. They can present after 3 months of age at any point of time. And alpha thalassemia can again present based on the severity in fetal life or at the time of birth or in childhood. The most important is nutritional anemia in our country, and usually this nutritional anemia is seen after 6 months of age. Then coming to the gender, you all know that X-linked diseases are more common in males, like the G6PD deficiency. And the place from where a patient is hailing from is important. It also gives you a clue to the diagnosis. So this is the image. We can see that so the thalassemia belt is usually located in this particular region, the Punjabis and Sindhis. And this red rectangle over here is basically the sickle belt of India, which is the central India, including Orissa, Madhya Pradesh, Andhra Pradesh, Jharkhand, and few pockets in Karnataka and Tamil Nadu as well. And HBD, as we all know, it is common in Punjab, and HB is the green dots, which is usually seen in the northeast. So if you know the place from which the patient is hailing from, you can, again, it gives you a clue to what could be the cause. Then coming to nutritional history, if there is history of improper weaning in the child with predominant milk-based diet, which is what we commonly encounter in our daily OPD practice, and if there is history of pica, geophagia or pagophagia, it's again a pointer towards iron deficiency. Then there are some drugs which can result in anemia, especially in hemolytic anemias like G6PD. We can have some oxidant drugs which can again induce hemolysis in them. Antiepileptics are known to cause anemia, especially phenytoin. And methotrexate, if we use, the patient can end up having megaloblastic anemia. So history of drug intake is also important. And then coming to the perinatal history, if a child had history of NNJ requiring phototherapy or DVT or blood transfusions, again, a pointer towards maybe an underlying hemolytic anemia. Similarly, a family history of jaundice or gallstones or cholecystectomy or splenectomy, again, is a pointer towards a probable hemolytic anemia in the family. So whenever a child with anemia comes to the OPD, a few algorithms, if we follow, it will be quite easy for us to kind of find out what could be the probable etiology for anemia. So the first and foremost thing is, if at all a child is presenting with anemia and is having unconjugated hyperbilirubinemia, it's a pointer towards hemolytic anemia, and you can further prove it by doing other ancillary investigations like plasma urine hemoglobins, LDH, etc. So that would be it. And if a child is having anemia with thrombocytopenia, that means there is bicytopenia. And in that particular child, if you have organomegaly, it is a pointer towards marrow infiltrative disorders. So that could be a wide variety of conditions like leukemias, HLH, and storage disorders. So if there is bi or pancytopenia and the child is having organomegaly, you will think of marrow infiltrative pathologies. But if there is no organomegaly and there is bi or pancytopenia, it indicates that there is a marrow failure. So we have etiologies like aplastic anemia, inherited bone marrow failure syndromes, and you can even have megaloblastic anemia, which will again present with severe megaloblastic anemia can have pancytopenia. And immune thrombocytopenia again will have thrombocytopenia, and it is always quite common to have an associated anemia in such children. So that would be this side. So if we move on, if the child is having plain anemia and there is no other cell line involvement, then based on the presence of organomegaly, again we can classify them into two categories. So if we have organomegaly, it will again be your hemolytic anemias, which can be your immune and other non-immune causes of hemolytic anemias. Non-immune would be again membranopathies, enzymopathies, and hemoglobinopathies. And then we can have ineffective erythropoietic disorders like thalassemia, congenital dyserythroplastic anemia, or sideroblastic anemia. So that would be coming into a category which present with anemia and plain anemia and organomegaly. Suppose an individual a child had presented with just anemia and there is no organomegaly on examination, so we have to think of these causes. The most common that we see is a nutritional anemia, and celiac disease is again common in this part of our country, so we have to keep that in mind. And Diamond-Blackfan anemia or PRCA usually presents with macrocytic anemia in the infantile age group, and they do not have organomegaly. So this is one approach based on presence of jaundice, presence of other cell line involvement with or without organomegaly. So another way we can classify anemias is basically based on the marrow production. So there can be conditions where the marrow is not functioning properly and there is decreased production. If you just broadly think of it, the causes that come to mind would be either the marrow is failing, that is aplastic anemias or your inherited marrow failure syndromes, or sometimes there is infiltrative disorders of marrow and the marrow is not able to produce the cells. And sometimes you can have ineffective erythropoiesis as in congenital dyserythroplastic anemia and other conditions like DB and Pearson syndrome. Then comes coming to the increased destruction. So we can have anemias because of increased destruction. We have seen that earlier. So the non-immune causes would be most commonly these three: membranopathies, hemoglobinopathies, and enzymopathies. Other conditions that we can have would be the thrombotic microangiopathies, etc. And then your immune-mediated hemolytic anemias. And anemia can also result if at all a patient is having a blood loss which is either acute or chronic. So based on the production or destruction, we can divide anemias into these particular groups. Yeah, you can ask any questions. Then, so after that, so we can again, so these are the ways of trying to arrive at a plausible etiology. One more classification is based on your mean corpuscular volume. So we can again divide anemias based on your MCV into either microcytic anemias, normocytic anemias, or macrocytic anemias. So that again in each of the categories based on the reticulocytosis, we can again divide them into two different groups. So predominantly if you have a microcytic anemia and with no or relative reticulocytopenia, it is usually your iron deficiency anemias, beta thalassemias, and sideroblastic anemias. So that would be coming into this group. And if you have a normocytic anemia and if you're having reticulocytosis, all the immune, non-immune mediated hemolysis will be usually normocytic with elevated reticulocyte count. And no reticulocytosis would usually be seen in conditions like transient erythroblastopenia of childhood or in anemia of chronic disease or malignancies. But sometimes when you have hemolytic anemias where the hemolysis is going on at a very rapid phase, then you can end up getting a macrocytic anemia with reticulocytosis. So all these conditions can be seen here as well. And if you have a macrocytic anemia with no reticulocytosis, again you have to think of marrow failure syndromes or megaloblastic anemia or aplastic anemia. Then we have already seen that we will think of hemoglobin, we will think of a hemolytic anemia if a child had presented with anemia and is having unconjugated hyperbilirubinemia. So again, hemolytic anemias can be divided into a category where usually they present with acute or episodic hemolysis. Episodic hemolysis and acute presentation is common in G6PD deficiency and AIHA. HUS and TTP spectrum disorders are also do have an episodic presentation. And then we can move on to those categories where there will be chronic hemolysis going on. In them, again, based on the reticulocyte count, you can divide them into two groups. If at all the reticulocyte count is elevated, the most common ones which we will be seeing in our OPDs would be hereditary spherocytosis or maybe an autoimmune hemolytic anemias. They present with elevated reticulocyte count and hemolysis going on for a while. And if at all there is chronic hemolysis with relative reticulocytopenia, again you have your ineffective erythropoiesis like thalassemias. Now that we have seen how to arrive at an etiology, let's come to some of the most important RBC indices which will help us in doing so. First would be your mean corpuscular volume, which stands for the average volume of the red blood cell. And in children between 2 to 10 years of age group, anything which is usually less than 70 femtoliters or more than 95 is considered to be abnormal. Based on this formula, you can get the lower and upper limits of MCVs, and you can, or broadly remember that less than 70 or more than 95 is abnormal. And based on that, again, you can find out what could be the etiology. Another important index would be MCHC, which is a measure of the cellular hydration status. Normally, it is somewhere around 30 to 34 gram per deciliter, and usually it is high in hereditary spherocytosis. And it's somewhere around more than 36 gram per deciliter, and it is reduced in iron deficiency. So if at all you're having a normocytic anemia with a elevated MCHC and a preserved RDW, it is very much likely that you're dealing with a hereditary spherocytosis, and you can do confirmatory tests to prove the same. Another index would be your red cell distribution width, which is the measure of anisocytosis. So an increased RDW means that you have cells of all different sizes in the circulation. So that usually happens in iron deficiency anemia or in thalassemia intermedia or major phenotype and in hemolytic anemias. The normal range would be somewhere around 11.5 to 14.5%. You can use this RDW in distinguishing iron deficiency anemia from other causes like thalassemia trait and anemia of chronic disease, because RDW is elevated in iron deficiency anemia and however it is preserved in thalassemia traits. So your iron deficiency as well as thalassemia trait usually present as a microcytic anemia. So one of the soft pointer towards what could be the etiology would be the RDW. Then coming to reticulocyte count and related indices. So we all know that reticulocytes are early cells in the stage of RBC maturation. So whenever there is anemia, the bone marrow usually tries to compensate for it by increasing the RBC production, and the reticulocytes are usually released prematurely into the circulation, and you have an elevated reticulocyte count. So normally, the normal range of this reticulocyte count is 1 to 2%, and it is considered high if at all it is more than 2%. But as we have already seen, if a child is having anemia, the normal response of the bone marrow is to try and produce more reticulocytes, and prematurely this would be released into circulation, and usually you have a high reticulocyte count in setting of anemia. So that is the reason why you should get the corrected reticulocyte count, so that for the desired hematocrit we should see what is the reticulocyte count. And then we have to decide whether it is an elevated reticulocyte count or a reticulocyte count which is elevated just because of the anemia, but that is normal compensation. Similarly, another index is this reticulocyte production index. This is also, again, to find out the amount of bone marrow response, whether it is adequate or not. It is again simply given by this formula, which is the corrected reticulocyte count by the maturation factor. And this correction factor keeps differing based on your hematocrit value. So if at all a reticulocyte production index is less than... Yes. Yeah. Using this formula, we are supposed to calculate reticulocyte production index to see if the bone marrow is adequately responding to the amount of anemia in a child. So if the reticulocyte production index is less than 2%, it indicates that the amount of marrow response to the anemia is not appropriate. That would be nothing but ineffective erythropoiesis in the setting of an anemia. And if you have this reticulocyte production index of more than 3%, it is indicative that the marrow is functioning appropriately to compensate for the amount of anemia. So whenever you are having a child with anemia, reticulocyte count, reticulocyte indices provide a useful information as to what type of anemia you're dealing with. And if at all your reticulocyte count is elevated, it indicates that you're dealing with probably hemolytic anemias or anemias where there is increased destruction of the red blood cells going on. So corrected reticulocyte count is to correct for the extent of anemia or the degree of anemia that you are having. So normally if you have a hemoglobin of 3, they obviously have a reticulocyte count which is elevated than a person who is having a hemoglobin of say 9 gram per deciliter. But that doesn't mean that it is an elevated reticulocyte count. So you will correct for the normal hematocrit. Reticulocyte production index is basically to find out the marrow response. So sometimes also when you're having severe anemia, the maturation time of reticulocytes will reduce and they are prematurely released into the marrow. So that is the reason why for different hematocrits here, the correction factor is differing. That is nothing but the maturation time that is expected in the bone marrow. So it gives a correction for the peripheral blood anemia as well as what is happening in the bone marrow. So the bone marrow picture is also going to come in place, and based on it, you can more refinedly, you can say whether the bone marrow response is appropriate or not to the extent of anemia. So we need to calculate both of them. So this is the formula. This is the formula, the corrected reticulocyte count with this maturation factor. So this maturation factor would be these numbers based on your hematocrit. So if that patient is having a hematocrit of say 20, you will have your corrected reticulocyte count by 2.5. So you have to use it based on the hematocrit in the patient at that point. So the maturation time is reducing in the marrow when you're having severe anemia. So they're even more rapidly released. That is the number of days. That is the maturation time. Usually reticulocytes have a maturation time of around 3 days in the marrow, after which they're released into periphery. And this is the normal. Hematocrit normal is 45. And usually they stay in your peripheral blood for 1 day. That is the normal thing. But as the hematocrit progressively reduces, that means your severity of anemia is increasing, and then more rapidly these reticulocytes are released into the marrow. That means the maturation time in the bone marrow is reduced. So you have to use that based on the hematocrit. So is that okay? Okay. Then coming to another index, that would be your corrected TLC. So most commonly this happens in maybe cases like thalassemia major. Your electronic counters or your coulters will not be able to distinguish between your WBCs and the nucleated RBCs. So nucleated RBCs are the precursor cells precursor cells in the production. So usually they are a little large, and sometimes the coulter can be confused that it would be a WBCs because the normal size is larger than that of a normal RBC. So whenever you have a TLC of somewhere around 60,000 or something, and you're having NRBCs in your peripheral smear, then you have to use this formula, which is WBC into 100 by NRBC plus 100 to get a corrected TLC. And then you have to see whether the TLC is really elevated or it is the NRBCs which are being counted as WBCs by the coulter, resulting in a high TLC. So this is the scenario that you normally see in thalassemia major. So any place where your marrow is stressed, sometimes you get nucleated RBCs in the periphery, so you have to do this correction. So it is quite commonly encountered in your emergencies that thalassemia major coming in failure with a hemoglobin of 3 or 4 gram% is admitted, and then the child will be having a TLC of 60,000. So that doesn't mean that it is an acute leukemia with hyperleukocytosis. That is what we commonly see in the CBC prescription and the differential diagnosis kept by the junior resident. So sometimes you have to take the entire picture into consideration, like what is the age of the child, what was the presenting symptoms and everything, and then you have to come to a conclusion. So these are some common findings that you are going to find in the peripheral smear, and few conditions which are associated with it. So iron deficiency, you expect to see anisopoikilocytosis with varying sizes of cells with an elevated RDW, and you can find cells like pencil cells and target cells. Similarly, if you're having a megaloblastic anemia, you will have hypersegmented neutrophils, and there will be macrocytosis in the peripheral smear, and occasionally you can find giant platelets as well. And similarly, in all the marrow failure syndromes, inherited marrow failure syndromes, or your aplastic anemias, usually the peripheral smear will be showing macrocytic RBCs, and there will not be any associated megaloblastic changes. So that would be the difference between megaloblastic anemia and the marrow failure syndromes. Both will have an elevated MCV. And reticulocytosis is basically seen in, again, anemias with increased destruction. And they are stained with something called a supravital stain. So that is what is seen as this polychromasia in peripheral smear. So whenever you're seeing polychromasia, you should think that there is reticulocytosis that is happening in the patient. And similarly, you can find this basophilic stippling in thalassemias. And we have already discussed nucleated RBCs are seen in whenever your marrow is stressed out. Most commonly that we encounter in our scenario would be a thalassemia major, and even a JMML can also have this NRBCs in the periphery. Then we can find something known as Heinz bodies in this condition known as G6PD deficiency. So when there is oxidant hemolysis that is happening after exposure to drug, or maybe there is a trigger like fever in these individuals with G6PD deficiency, the hemoglobin that gets denaturated, it will be seen as Heinz body inclusions in the peripheral smear. So if at all you have that, you should think of these conditions. Similarly, we can have bite cells. So when you have the denaturated hemoglobin sitting in the RBCs, that is not a normal RBC. So the spleen tries to remove them from the circulation. And in the process, sometimes the entire RBC is not engulfed, only a part of the surface is engulfed, and you get what is known as bite cells. So if that is present in peripheral smear, again you should think of G6PD. And then you very well know about microangiopathic hemolytic anemias. Again, there will be increased destruction of RBCs in the periphery, and that can be seen as cystocytes, and sometimes you get helmet cells and fragmented cells. So that if that is seen in the periphery, again you should think of microangiopathic hemolytic anemia. And these are self-explanatory. Spirocytosis you would usually see in hereditary spirocytosis, but you should also know that autoimmune hemolytic anemias also have some spirocytosis in the peripheral smear. And then in hereditary stomatocytosis, you will have stomatocytes. In hereditary elliptocytosis, you will have elliptocytes, sickle cells and sickle cell disease. And in the thalassemia, again, we will be having a wide variety of abnormal cells. Then we come to what is known as these Pappenheimer bodies. So it is usually seen in conditions like sideroblastic anemia. So these Pappenheimer bodies are nothing but the RBC which is having iron granules in the cytoplasm. That is not normal to have iron granules in the cytoplasm. That is usually seen as these Pappenheimer bodies. So if you use iron specific stains, that will stain, these bodies will stain with it, and then it again provides you a clue that you are dealing with conditions like probably a sideroblastic anemia. We'll move on to, I think I'll do only 2, ma'am, because the most common ones, 6 of them. We'll just focus on the investigations and the presentations rather than the treatment. So we'll start off with Mithun then. A 9-month-old baby had come with a history of pallor, progressive pallor for 3 months duration. And on history, we have found that it was the baby was a term baby, 3 kg weight was the birth weight, predominantly fed on diluted cow's milk, and there was suboptimal weaning, and the child was not on any supplements. There's poor weight gain, weight of around 6 kgs, and on examination, the child did not have any dysmorphism or physical anomalies. And on examination, child had pallor and there was no organomegaly. So what would be your thoughts? What could be the diagnosis? Differential? Nutritional anemia because? Why are you thinking? Yeah. Yes. Okay. So the most common thing that we see with this kind of poor nutritional history in our country would be nutritional anemia. So the investigations have shown, you can read out the investigations, what are abnormal in this. Okay. Sorry. For the degree of anemia? Okay. So what about? Yeah. So peripheral smear is again reflecting the same. There's anisopoikilocytosis. Your RDW is elevated because of that. Again, you have microcytic hypochromic RBCs with a reduced MCV and MCH, and they are again pencil-shaped cells and teardrop cells. So this is your classic iron deficiency anemia presentation, the investigations. So the parameters that will be seen in iron deficiency are all this that we have now discussed. If you send off an iron profile in this child, it is not required usually to confirm by sending an iron profile. You will usually see that the serum iron is less than 50 milligram per deciliter, and the total iron binding capacity is elevated, which will be somewhere more than 350 to 400 milligram per deciliter. And the transferrin saturation is classically less than 10%, and your serum ferritins are usually less than 10 microgram per liter. And if at all you look at the marrow iron stores, so obviously everything will be absent. So coming to the treatment of iron deficiency, you have to start the child on oral supplements, somewhere around 3 to 4 mg per kg per day. You can repeat a CBC with indices after 4 weeks. Expected response is a hemoglobin increase of more than 1 gram per deciliter after 4 weeks. And usually we have to give iron supplements for 3 to 4 months to build up the stores of the child as well. Most importantly, counseling the parents is very important about the diet as well as compliance to the iron supplements. Most commonly what happens is you do prescribe, but sometimes due to many other issues, the compliance issues with iron, usually the iron is not given properly, and then we end up working extensively that anemia is not getting corrected. So most importantly, we have to see that if the compliance to iron was good or not. So the Iron Deficiency Anemia Day is again celebrated on November 26th every year, just to so we all know that nutritional anemia is the most common cause of anemia, not only in our country but also worldwide. So we need to keep that in mind, and we also celebrate National Deworming Day on the 10th of February. And it also focuses on the importance of deworming, and every child should be at least dewormed twice a year. Dave wants to ask something. Staining of the teeth, we usually say that after giving the iron supplements, they have to, clean the mouth and all. But sometimes it is much easy. Maybe some of them say that if you give it just before bedtime, that would be helpful because these problems will be little less. But yes, sometimes some children do have too many issues with the. So as we know that it is a public health problem, we have seen that in the recent NFHS 5 survey also. So sadly, this is the NFHS 2, 3, 4 surveys, and these are the prevalence of nutritional anemia in children. The blue line is. So it was 74 and it has come to 58 in NFHS 4, but then it has again dramatically risen by somewhere around 10% by NFHS 5 data. So this is the program that has been launched by the Government of India, Ministry of Health and Family Welfare Initiative. Anemia Mukt Bharat, you will be getting it in exams. It is an important question. It is nothing but, with time, the anemia prophylaxis programs that have been going in the country have been modified. And we had a lot of programs, and then this National Iron Plus initiative and all of that has been now incorporated into this umbrella of Anemia Mukt Bharat. So in this particular program, they wanted to tackle anemia by using 6 interventions and 6 institutional mechanisms in 6 beneficiaries. So that is known as the 6 into 6 into 6 strategy. So this is what ma'am was talking about. So all the children in 6 to 59-month-old age group are supposed to get this bi-weekly iron folic acid syrup supplementation. I mean, you just remember only probably our pediatric age group recommendations, and that 1 ml of iron folic acid syrup is supposed to contain 20 mg of iron and 100 micrograms of folic acid. Similarly, in children between 5 to 9 years of age, they are supposed to get weekly iron folate supplementation. That 1 iron folic acid tablet, which is available again in the Anganwadis, is supposed to be containing around 45 milligrams of iron and 400 micrograms of folic acid. Similarly, there are recommendations for, so the 6 beneficiaries would be these 2 childhood age group, and then we have the adolescent girls and boys, they also need supplementation, and then the women of reproductive age group, and then we have pregnant women, and then the last would be lactating mothers. So all of them should be getting supplementation. And the 6 interventions that the program talks about is the prophylactic iron folic acid supplementation that we have just seen, and then in behavior change communication with delayed cord clamping. And then they have also focused on this fortified food in public health programs. So we have now dual fortified salts with both iron as well as iodine. And we do have iron fortified, iron fortified wheat and rice as well. So there should be, as per the program, mandatory provision of these fortified foods should be available. And then periodic deworming, we again saw this. At least twice a year we have to do deworming in all our children. And then testing of anemia using digital methods and point of care treatment. And then finally addressing some non-nutritional causes of anemia in endemic pockets, which will be adding to the burden of anemia with focus on malaria and hemoglobinopathies. So we've seen the 6 beneficiaries and the 6 interventions. So this is what we need to remember, and we have to give all our children prophylaxis, whoever comes to us. Most of them end up having deficiency and we need to treat them, but every child should be given prophylaxis. So sometimes even after giving iron, there can be some inadequate response to iron, as we have seen that after 4 weeks, hemoglobin should rise by 1 gram per deciliter. Sometimes, mostly it is the compliance issues and tolerance issues, which ma'am had already pointed out what we can do. And sometimes we can have inadequate dosing. So after looking for all these causes, and if a child is not responding to iron supplements, you think of other causes of your microcytic hypochromic anemia. Celiac disease is very common in our part of the country, and usually they present with short stature, anemia, loose stools, abdominal distension, etc. So this needs to be kept in mind. And then you can have other causes of microcytic anemia, that is your thalassemia traits or your sideroblastic anemia or anemia of chronic disease, and rarely you can have something known as IRIDA. So a child, so as ma'am had already said, iron deficiency anemia and thalassemia kind of share few common parameters on investigations. Microcytic anemia, peripheral smear looks the same. So how to differentiate both these conditions? Thalassemia trait usually has the RBC count which is maintained for the degree of anemia. But since iron is not there for production of RBCs, in your iron deficiency anemia, your RBC count is also going to go down. Then microcytic anemia is seen in both these conditions, but in iron deficiency anemia, you have microcytic and hypochromic cells which are seen equally commonly. But in a peripheral smear of thalassemia trait, usually it is predominantly microcytic cells rather than hypochromic cells. And then we just should remember that we are just talking about thalassemia trait, and it has got nothing to do with thalassemia major or transfusion dependent thalassemia. So this Menzer index should be used only in thalassemia trait. It is given by this formula of MCV by RBC count. And as we all just saw that the RBC count is usually reduced in iron deficiency anemia compared to the thal trait. So your Menzer index is usually more than 13 in iron deficiency, and it is less in the case of thal trait. If you send an iron profile, obviously if it is iron deficiency, you will find the findings accordingly, and it can be normal in the thalassemia trait. So that would be most common nutritional anemia. Another most common case that we would see is Abirami, you can take. So 11-month-old baby who's been exclusively breastfed. The baby had presented with acute gastroenteritis, and then on history taking we found that the child had developmental delay. There was some progressive pallor, and on examination the child had a chubby face with some hypopigmented sparse hair and hypopigmented knuckles. Did not have any dysmorphism or physical anomalies. No organomegaly on examination, but the child had some coarse tremors on examination. So what would be your possibility? Any specific, how can you explain the tremors? So there is something known as pre-infantile tremor syndrome and infantile tremor syndrome. So we are dealing with a probable infantile tremor syndrome, and pallor and all is because of the megaloblastic anemia component. So the investigations, you can see what is abnormal. I've put a corrected retic count over here for you. And anything else? So the peripheral smear, which, yeah, so we had some hypersegmented neutrophils and some teardrop cells. So confirmation of megaloblastic anemia. So you have to, you can send a B12 folate levels in the serum. Usually we don't do this, but we can send urine MMA levels, and it is supposed to be elevated in B12 deficiency. And RBC folate levels are reduced in folic acid deficiency with an elevated homocysteine. So we are dealing with a megaloblastic anemia. So the most important thing is, again, treatment. Folic acid deficiency, be whatever may be the age, usual requirement is only 1 mg in a day. So we have to give that folate supplements for around 2 to 3 months. Similarly, if someone is having cobalamin deficiency, what we do usually give is a stat corrections of 1000 micrograms IM or IV. Some people prefer to give it daily for 7 days, and some people give it for 3 days. And then we follow it up with some either daily oral supplementation or weekly parental preparations for another 2 to 3 months. But if we are dealing with an infantile tremor syndrome, it is due to multiple micronutrient deficiencies, which is quite common in our scenario. So we need to give other micronutrient supplementations as well in these patients. And most important thing is parental counseling in nutritional anemia, be it iron deficiency or megaloblastic. And diet modification is the most important component that you have to keep in mind while dealing with the treatment of nutritional anemia. So coming to the third case, they maybe 5-month-old. Okay, I agree. So investigations, so we are dealing with, so most of the times these hemolytic anemias with the anemia and the hypodynamic circulation, they give a non-specific complaint of fever. That doesn't mean that probably we're dealing with some marrow infiltration, leukemia and all. It can very well be some hemolytic anemia. So it's a case of beta thalassemia major. How do you confirm the diagnosis? We do a HPLC, and this is how the histogram of the HPLC report is usually shown. So in this particular diagram, we can see that there is a peak in the HbF region. So that is what is that is what happens in beta thalassemia major, and clinching the diagnosis. And sometimes, if at all you have a child who has got a recent transfusion, to confirm the diagnosis, we can either send parental HPLC, the mother and fathers. That is what we usually do. And sometimes you can do the genetic testing. So we have to, so after the diagnosis, we know that we have to keep the child on regular transfusions, and we want to keep a pre-transfusion hemoglobin always of more than 9 g% to suppress the extramedullary hematopoiesis that is going on, as well as maintain the hemoglobin at a decent level to meet the physiological demands, and so that the child's growth will be well. We give them folic acid and calcium vitamin D supplementation, and we have to start chelation in all those who have received more than 10 transfusions, or if the ferritin is more than 1000. So that needs to be kept in mind. Most important component would be your antenatal counseling. Since it's an autosomal recessive disorder, there's a 25% chance that it can recur in the future. So the parents should know that, because it is sad that if you have a child with thalassemia major, you again go and have another child with thalassemia major. That's going to be a huge financial burden on the family. Definitive treatment would be matched sibling donor hematopoietic stem cell transplant if it's available, but usually many of our patients cannot afford it, and we keep them on regular transfusions. And with all possible supportive care, they do lead a decent life with regular transfusions. So it is important to diagnose it. So I think, ma'am, but it's already 8:50. Right. So maybe we can take up another case. We have a 1 year, 9-month-old who presented with fever, progressive pallor, and passage of cola-colored urine for 4 days. And on examination, the child had tachycardia, tachypnea, and on also had pallor with hepatosplenomegaly. Kiran, you want to come? So hemolytic anemia, where probably an intravascular hemolysis because of the history of this cola-colored urine with pallor and all. So investigations, anemia with reticulocytosis with the peripheral smear, which is again showing white cells and blister cells. So the investigations have shown that there was an LDH which is elevated again. The DCT you have done because probably hemolytic anemia, it was negative. G6PD done at the time of presentation was, so this is how it is quantitatively mentioned as 22 international units per gram of hemoglobin, but this is normal. So the G6PD was again repeated after 3 months later, and then it was found to be deficient, which was somewhere around 3 international units per gram. So we are dealing with a G6PD deficiency case, and it is an X-linked recessive disorder, and the global prevalence is somewhere around 4.9%, which is a little bit more in India. Indian prevalence is around 8.5%. So you can have 2 types of presentation. Most common presentation that we see is episodic hemolysis that happens when the child has some stress. Maybe there was exposure to drug or exposure to or there was some fever or any infection that it would have triggered. And other very rare clinical syndrome is a chronic non-spherocytic hemolytic anemia. And the common variants usually are G6PD A and B. A is usually seen in African Americans where the enzyme activity is around 5 to 15%, and B in Mediterranean people where the enzyme activity is less than 5%. So what we should remember in G6PD deficiency is that a child presenting with acute hemolysis, you're thinking of G6PD, but normal G6PD will not rule out G6PD deficiency at the time of ongoing hemolysis. The reason is that when there is ongoing hemolysis, you have new RBCs which are being produced, and they usually have normal G6PD levels. So that test has to be repeated after, say, 2 to 3 months to confirm the diagnosis. And then when someone is having an acute hemolysis, the indication for blood transfusion is if you have a hemoglobin of less than 7. Or if you have a hemoglobin of less than 9 and the child is having ongoing hemoglobinuria that is happening. So that you need to remember. And whenever you're admitting a child and you're transfusing a child, doesn't mean that you just transfuse and discharge the child. The child needs to be observed, and if the hemoglobin is more than 9 but you're having hemoglobinuria persisting, or if your hemoglobin is between 7 to 9 gram per deciliter but the child is not having hemoglobinuria, you should observe the child at least for 48 hours, because it is very well known that you discharge, the hemoglobin drops again and the child can come in failure and anything can happen. Then another rare presentation is the chronic non-spherocytic hemolytic anemia. They present with chronic anemia, and sometimes we need to give them blood transfusions to maintain the hemoglobin levels again for proper growth. And in severe cases, a splenectomy can be done in cases of hypersplenism or massive spleen, which can happen in this particular presentation. So most important thing is acute hemolysis, transfuse, observe the child. Only when the child is stabilized after 48 to 72 hours you discharge. And then you have to treat the underlying condition. If at all there was an infection that had triggered the hemolysis, that needs to be treated. And the parent should be counseled about, they have to be educated, and there should be a heightened vigilance that this can happen in future if at all the child takes some impending drug which can cause hemolysis, or maybe the child ends up with any infection or fever. So the parent should be counseled, and there's a huge list of drugs that should be avoided in G6PD deficiency, and that has to be given to a patient, to the parents whenever such scenario occurs. So I think we will run through. We've covered the most common causes of anemia. So the most important thing is we have seen the algorithms. So most importantly, always thorough history and clinical examination will give you a clue to what you're dealing with, followed by your investigations. So complete blood count with reticulocyte count and RBC indices and your peripheral blood smear they will give you a clue to what you're dealing with probably. And sometimes if you have a very good pathologist, the peripheral smear findings sometimes can clinch the diagnosis. And we have seen various algorithms, MCV based, reticulocyte count based, that can help in delineating etiology. So based on what you're thinking, you will go ahead and do the specific diagnostic test for confirmation. Just remember that whatever be it, nutritional anemia is the most common cause for anemia in our country, and that we should not forget, and we should always treat it, and we should give prophylaxis for our children. Thank you.